Welcome everybody tonight to our program. In partnership with the Doctors Company, we would like to welcome you to our latest webinar, which is entitled Managing the Non-Compliant and Non-Adherent Patient. Our speakers from the Doctors Company tonight will be Kathleen Stillwell, who is the Senior Patient Safety Risk Manager, along with Mr. Richard Cahill, who is the Vice President and Associate General Counsel. Both Kathleen and Rich have their cameras off tonight since we're having a little bit of technical issues while we were running our AV technology check. But we do have the slides up, and Kathleen will be going through those as well as Rich throughout the program. Now, before I hand things over to Kathleen, I wanted to remind everyone that tonight's webinar has been approved for 1 hour of CME credit. I'm going to type the link to claim the CME credit in the chat box below. And Kathleen also is going to be displaying a slide with a QR code that you can scan from your phone and then apply for the CME credit at the end of the program as well. We have reserved time for questions at the end of the program. So if you have any issues or questions that come up as we're moving through tonight's presentation, please feel free to type them in the chat box down below, and we'll get to them once Kathleen and Rich have finished. And now I would like to introduce Kathleen Stillwell. Kathleen?
Thank you very much, Jen, and our gratefulness to the San Diego County Medical Society for partnering with us to present this program to the wonderful physicians and providers in San Diego County. Tonight's program, and I will get back to the QR square, is Managing the Non-Compliant and Non-Adherent Patient. And this is a new program that we developed based out of the huge escalation in calls over the last year and a half in this post-COVID or ending COVID period, that patients seem to have really gone off the rails. They don't want to do this, they don't want to do that. They're asked to get tests, they're asked to come back. They don't come back. They didn't want telehealth in the beginning. Now they don't want to come in the office. They only want telehealth. So we're looking at a lot of increased consternation of patients who are making it challenging for you and your staff to take care of them. This program is going to provide 1 hour of CME credit. And so if you have a smartphone, you can open it to the camera and scan the QR code, and it will take you to this image on the other side, and you will put in your name, your license. Just put in your MD, DO, RN, PA, NP, because the nursing board and PA boards also give 1 credit hour of continuing education with our certificate. At the end, there will be a reference to the evaluation, and you have until 5 p.m. September 25th, which is 5 business days after today, to claim your CME. We are not going to go through the objectives. I'm not going to go through my bio. I'm going to just briefly mention Rich's, except to say that I am take care of a lot of accounts that are really struggling still coming out of the aftermath of COVID. And their biggest struggle, besides loss of staff or staff getting sick and financial loss, is this non-adherent, non-compliant patient. Rich tonight, I have had him on every program we do. We present everything together. He's extraordinary. He's got over 35 years of malpractice defense work in his background, and he has been attorney for some of the largest health plans in California, Cigna, Kaiser, Tenet, and he is very skilled and understands what you go through because he's represented physicians that have been sued. You know, I like to start with inspiration, and when we started to put this together, I found my inspiration from Charles Dickens, who wrote in 1859, "It was the best of times, it was the worst of times." And I think we can say that about the last 3 years. We've had some best times, but we've also seen some of the worst of times. I want to begin by differentiating adherence and compliance. Compliance is a passive behavior where the patient is following a list of instructions from you. And you say, do this, take this medicine, get this test. That's compliance. That's what we mean in compliance. Adherence is a more positive, proactive behavior, which results in a lifestyle change by the patient who has to follow a daily regimen. It could be following a certain diet if they're diabetic, eliminating salt, eliminating certain foods based on their cholesterol, or if they have high blood pressure. So adherence is where the patient understands and has been educated to, you need to make these changes, or everything I'm doing for you isn't going to help you get better. If you don't take the medication, then your gastric ulcer is not going to get better. And that is the compliance is taking the medication. Adherence is the patient understanding their role. And why must you document both? Because I'm going to tell you straight out, we need it for rebuttal for medical board complaints and rebuttal to health plan grievances, because that's what's escalated. It hasn't been an increase in litigation at this point. It's all about the medical board, because the patient calls or makes an online complaint to the medical board that they didn't get what they wanted. I called the office and the doctor refused to see me. Well, that's because you said you haven't been in over a year and you have to come in. I can't do telehealth. And the patient takes that as, you didn't agree to see me, you're abandoning me. And that's what they tell the medical board. And then the same thing with the health plan grievances. They go to your health plan, and then health plan's all over you to have a response. Our MediGuard coverage, we assist with those responses. So we always ask, if you get a medical board letter or a health plan grievance letter, that you let us know so we can give you some guidance. And we do need it for defense in case of litigation, because if you have documented non-adherence and non-compliance, that's critical to the defense of the care that you provided. And we also want to have that documentation if we need to dismiss a patient from the practice. For instance, dismissing a patient is always a last resort. But at HMOs, you have to show 3 strikes before they'll agree, and you have to call them to say, Joe Blow was nasty in the office, nasty on the phone, and rude in the office for the 3rd time, and we want to dismiss them. And they're going to say, I need to see the documentation for 3 episodes. So that's
Kathleen,
why don't give a pass to people.
Kathleen, it looks like your slides may be frozen. We're still showing the difference between adherence and compliance slide, and it looks like it may have frozen on that slide.
Oh.
Do you want to try to shift? There you go. Perfect.
Okay. So I just covered the slide that you didn't see, and then Perfect. It backed up. Now let me go. It just auto backed up on its own. Yeah, we found in our practice we were having some challenges. Outcomes of non-compliance and non-adherence. I think this list is pretty obvious to you, but I'll see it's advancing without me even touching it. Hold on, bear with us, we apologize. It can have an impact on a patient's outcomes clinically, increased risk for complications, delay in getting the right treatment, or maybe a delay in getting tests done so that you can refer them to a specialist, because that's what they really need. And if there's a delay in a referral, that can come back you on litigation, on complaint to the medical board. Patients say, I had to have this surgery because you didn't do this and you didn't do that. So it's really important. And of course, it's an incomplete treatment, and that increases cost. Let's talk about the physician-patient relationship. There's a negative impact on that when the patient feels like you and the patient aren't in sync. And then I think the thing that is really most threatening is harm to your brand and reputation, because this sends patients to social media to post. Jen, please interrupt me if my slides aren't advancing. We're now looking at common causes of patient non-compliance and non-adherence. Is that showing?
You are seeing that one, but it looks like there's another slide kind of hidden behind it as well. So I think the transition is getting a little bit muddy.
Okay. You might want to bring your slides up, and I'll transition after this slide and have you put your slides up. Will that be okay?
Sure.
So on this, what we're looking at is common causes of patient non-compliance and non-adherence. They don't understand, they don't comprehend the information you give them. There can be language barriers, cognitive abilities. You have people of all ages who have sometimes some cognitive issues, low health literacy. That doesn't mean they can't read. That means that they're not getting it. They don't process the information, and that can be for a variety of reasons. They can be college educated and have low health literacy. And then this one about personal reluctance to ask physician questions, because I researched this to see what are the most common reasons we see. And sometimes they're not comfortable personally. There could be a cultural difference, or they just feel that they haven't established a patient-provider relationship with you and they're not willing to ask questions. They're reluctant. Sometimes they have somebody with them and they're not comfortable asking the questions in front of the party that's with them. Some patients obviously have drug or alcohol dependence. There are medication side effects and denial or diagnosis of illness. I'm going to move to the next slide. Did it come up okay?
That's great, Kathleen. Thank you.
Is it okay?
Yep.
All right. Social determinants of health. I just want to remind you, these are all the things that impact the patients, to understand what you're trying to tell them about taking care of them and what they need. They're worried about their housing. They may have no insurance. And I'm just going to throw financial in there. They may be running out of money. Excuse me. Discrimination, community, health literacy. They have a lot of things that prompt them to be absent while they're listening to you. You know, they hear your voice, but they're not processing. And this again comes back to literacy, culture, inclusion. These slides are intended to meet the state requirement for cultural linguistic competence and implicit bias content. So I'm not going to spend more time on them. A big problem is medication adherence. And I want to talk about two types of medication adherence. First is intentional, and then we have unintentional. And so what is the difference? Medication non-adherence to prescribed treatment is thought to cause 125,000 preventable deaths and $100 billion in preventable medical costs per year. And this same data shows up in a number of studies by very reputable organizations. The World Health Organization reports up to 25% of hospital admissions result from non-compliance. They also report 125,000 people with treatable ailments die every year in the USA for not taking their medication properly. Adherence rates for most medication for chronic conditions such as diabetes and hypertension in the studies fall in 50 to 60% range, which means 50 to 60% of the time, or 50 to 60% of the people, take your pick, only half the time they're even taking the meds. In most studies, adherence, and that is, well, the patient is adherent, is defined as taking the medication 80% or more of the prescribed dosages. So they're not even striving for the 100%. Not taking medication as prescribed can account for 50% of treatment failures. So when you're thinking the patient's not doing better, they're not getting better,
Kathleen, your slide did not advance. Can you try advancing?
I will. I'll back up. It did for me. I backed up. Now I'm going to try again.
There you go. You're there.
No, on my screen, I'm still on the same old slide.
Go forward one more, please.
Do you have not taking medication is 50% of treatment failures? Do you see that?
We're still on the last slide that you just covered. There you go. Now we're on the correct slide.
Okay, I think there's about a 9-second delay in the slides transitioning. That's what I think is happening. I'm trying to count it. So 32 million Americans use 3 or more meds daily. 75% of adults are non-adherent in one or more ways. And we already talked about it's $1 billion a year. Now I'm hitting the button, but it might take about 9 seconds. So I'm going to go ahead and talk about what factors influence medication. And if you can just give me a hey when that slide shows. Research indicates there are multiple issues that influence adherence. Fear of side effects, cost of medication, misunderstanding when taking multiple medications, lack of symptoms, patient beliefs, mistrust, worry becoming dependent, and depression. Did it come up?
It did. Yep.
The number one problem for patients over 65 is they forget to take medications. A recent poll of US individuals 65 and older found 51% of the patients in the survey take at least 5 different prescription drugs regularly. 1 in 4 takes between 10 and 19 pills a day. 57% polled admitted they forget to take their meds. Sometimes they forget to take all their meds for the whole day. Or they have so many to take that they take them slowly and they're kind of taking them through the day because it bothers their stomach, or they have all kinds of reasons. They're not someplace where they can take them. And they just think, well, I'll just skip that dose today. Among those patients using 5 or more medications, 63% said they forget doses, compared to 51% of those who take fewer medicines. So it makes sense. People who take more medicines are less compliant taking them. Is that slide showing, Jen?
Yep, we've got it. Thank you, Kathleen.
Potential barriers. I'm not going to spend much time on this slide except to say that you see there are patient-related barriers, there's treatment barriers, but I want to look at other barriers. Poor practitioner-patient relationship, or an asymptomatic disease being treated. That shows up a lot in the studies. People say, well, I took the medicine and I felt better, so I stopped taking it. And it's really important when you're querying your patients, and you can train your MAs because they room the patients and they do the medication reconciliation before you even come in the room to have them ask the patient, because they're more disclosing to the medical assistants than the physicians. The studies show that they want to please the physician. They don't want to say, I didn't do what I was supposed to do. I didn't do what you told me. But if the MA says, sometimes do you miss some of the doses of some of these meds? Yeah, I do sometimes. Which ones do you think you miss most often? Well, the red one or the blue one. They might not even know what it is. So have your staff help you figure this out. Strategies to improve medication adherence. And this is to help you understand that patients' medication.
We just the potential barriers slide just showed up. So now we are waiting. There we go. We're on strategies to improve.
Okay. So you need to understand that the patient cannot improve their medication adherence, and that is taking it. And if they don't take it, that becomes non-compliant, unless we understand what causes them to miss taking it. So you have to consider, are they living alone? Do they know that they need to order prescriptions from the pharmacy that do not have child-proof bottles? Are they forgetful? Do they use a pill box? Does somebody fill their pill box? Does somebody only fill it for a week and the person didn't come back, and they would do better if they had a 2-week pill box? Also talk about the side effects. Ask patients to take notes. As you take a piece of paper, I want you to write down something really important. Never forget to take the red pill, which is whatever it is. So you give them that note, because that's a visual for them. And then also, what time of the day are they taking them? Patients get very confused. They say, well, I have to take 5 meds. One I can't take with food. One I have to take 2 hours before I eat. One I have to take 2 hours after I eat. So I don't know when to take it. So I just usually skip it because I don't know if I ate, how long ago I ate. I don't know if it's been 2 hours. And then, of course, a financial burden. And please always try to order generics, because that's helpful. And the patient sometimes can get a discount coupon from some of the pharmacies and some of the vendors. Assess their health literacy. To what degree do you think this person is really able to process and understand the health information? Use repeat back. You know, you do this with your toddlers and teenagers. When you tell them something, if you tell your teenager, okay, you can go out, but you know what your curfew is, and you have to be in the house at midnight. That means not turning the corner, driving down the street, or pulling in the driveway. In the house. Do you understand that? Yes, I understand. I know. You don't have to tell me 10 times. Yeah, I do. Now I want you to tell me, what is your curfew and where do you have to be at that time? And what you want to remember, it's 11, it's midnight, and I have to be in the house. It's a repeat back. It's a toddler. And this is what we have to do with toddlers and teenagers. Reducing complexity. If there's something that they could just take a daily dose. My grandson was recently prescribed a medication. He's 19, and they said you got to take it 4 times a day, and you have to drop a pill into the 6 ounces of water and take it 4 hours a day. You can't take it with food, and you have to take it either an hour before or an hour after you eat. And he wasn't doing better. He's got a beginning of an ulcer. And I said, are you taking the medication? He said, no, I can't take it 4 times a day. I'm working. I'm not somewhere where I can just stop and take a drink of water. And I can't do that. And I just take it in the morning, and I take it at night. I don't get it during the day. So he went to the GI doctor this week, and I said, tell him that you can't do it. And you know what the doctor said? Great, I'm going to prescribe you a pill you only have to take once a day at night. And then he said to the doctor, why didn't you prescribe that in the first place? No answer. Prescribe combination meds if available. Send reminders, and have somebody call and check, especially with your patients who have cognitive issues, and say, do we need to have some help to check on them? You were here last week, doctor prescribed some new medication. Your receptionist can make a call. Receptionists are not on the phone all day long. They can make calls. Doctor just wanted me to check. Do you know what that means to a patient when they hear, oh, the doctor wanted her to check and see how I'm doing on this new med, and then make a note in the chart that they checked. Don't forget the note in the chart. Engage community pharmacists. Pharmacists, and tell your patients, every pharmacist loves to give education. Every time I get something and I go through the drive-through, they'll say, this is a new med for you? The pharmacist would like to talk to you. And I say, thank you. Tell them not today. I know about this medication. I've taken it before. It's just the first time I got it here. So I know. But if there's something new and I'm in the pharmacy, sometimes I just let the pharmacist tell me, because I want to hear how great they are explaining it. Technology is important. There are many e-pill devices now that open when the patient has to take the pill. Christmas is coming, Hanukkah is coming. This is a great gift to give somebody who can't remember. An automatic pill dispenser, timers. This will all help to improve patient adherence with their medication. The most helpful things I have ever done with non-compliant patients have been to ask questions, not to lecture, and to be willing to listen to what patients say. This is a statement from Fred Kleinsinger, MD, who is a trainer, team leading physician for Kaiser Department of Medicine. And I loved what he said, because when I was doing the research, what's the best thing to say to a patient who's non-compliant? This statement kept coming up, and I thought, I'm going to put it in. Not lecture, but ask questions. What prevents you from taking medications? What would make it easier for you to take your medications? Now we're going to transition to overcoming barriers, non-adherent and non-compliant patients. And this gets right into the meat of things. And of course, you know who I have here, the fabulous Richard Cahill, our Vice President, Associate General Counsel. And Rich, I'm going to turn it over to you.
Thank you, Kathleen. Good evening, everyone. This is Rich Cahill. I'm Vice President and Associate General Counsel with the Doctors Company. Kathleen has put together a very important program for us. I recently have published 2 articles on non-adherent and non-compliant patients. And at the end of the program, Kathleen will give you the link for those. Those provide you in narrative form some of the issues that we'll be talking about. So what are some of the examples that we see? Failing to participate in recommended treatment plans. That's a common problem with patients. Missing or canceling follow-up appointments. They either don't show up, or they forget to come and then they don't tell you anything. Or they discontinue therapy or medication regimens prematurely. One of the problems that I found in defending healthcare providers is that patients feel better, so they stop taking the medications. And of course, that's very bad. Part of the problem is it makes the medication less effective. And then you have to go to a second or third line medication, which may create problems in continuity of care. Or they're provided with a specialty referral and they forget to follow up, or they don't obtain laboratory tests as ordered. This is particularly a problem with patients over 65 years of age or older. Or you have established policies that they've been advised about either on the website or in the conditions of treatment or in the various written instructions, and they simply forget to follow up as instructions. And these are important as payment, treatment, safety precautions, and practice procedures. So make sure as you're working with patients that this isn't an ongoing problem. And as I indicated, it's particularly difficult with patients over 65. Identify and address compliance barriers. And this includes, as Kathleen indicated, health literacy. You may have a well-educated patient.
Can I interject, Rich? Can I interject one quick second? Kathleen, can you push the slide forward one more time, please? There you go. Nope. One more.
Didn't go?
It's frozen between the examples of non-adherent and non-compliant, as well as identify and address compliance barriers.
Is that okay?
Not yet.
It's frozen, Kathleen. Also, there are problems with language or cultural barriers where someone, either because they don't understand the instructions or because of cultural barriers, they're not able to follow the instructions. Also, some patients, particularly those with younger or older patients, they're unable to comply because they have an elderly patient or a child to take care of. Transportation can be a problem, and we saw that particularly true during COVID, where patients were concerned about getting on transportation provided by the public because they were concerned that they might be exposed to COVID. And financial issues, which becomes something that's particularly difficult for patients that are on Medi-Cal or Medicare. So what strategies can you use to enhance the compliance and adherence? If, as you're working with a patient, they're experiencing difficulties in communicating, ask them to articulate what issues are preventing them from following the recommendations. And generally, they'll be able to advise you, and you can work with them to help correct the problems. Also, use a translator for patients with limited English proficiency. And this does not usually include family members. If you need to have some type of translator, make sure you know that in advance, and you can work with their health plan to make sure that they have the appropriate translator. Kathleen mentioned the repeat back to validate the understanding. If you ask the patient, I'm going to tell you what your instructions are, and I want you to repeat back, it has statistically a significantly increased chance of success if they repeat that, because now they've understood and processed it and are able to tell you what it is you're telling them to do. And that includes them saying, what is my main problem? What is that I need to do as the patient? And why is it important? If they understand those three critical issues, there's an increased likelihood that they'll be able to improve the compliance issues. Next slide, please. Next slide. We're currently on 29, and we need to be on 30.
I'm on 30. It's
okay. Okay, thank you, Kathleen. If we could be on 30, please.
I am on 30. That's what I'm saying. It's not showing.
Okay.
It was on 30, Kathleen, and then it bounced back to 29.
Okay.
Consider including requirements in the conditions of treatment, and those would be something that would be posted both on the website so they understand what their obligations are, and also I think it's a recommended way to deal with patients so that they know at the outset what you expect of them, and have them sign a conditions of treatment, recognizing that these are the requirements that the practice expects them to follow up. Part and parcel to that is, as you're introducing new patients to the practice, have a welcome letter with important information about your practice procedures. That would include things such as language, follow-up appointments, making sure that they follow up with medication instructions and so forth. And if they have that available to them in writing, both on the website and in a welcome letter, as you're working with them, patients want to try to make sure that they comply. That's also helpful in circumstances where patients are non-compliant and it's a chronic problem. And it's important because non-compliance and non-adherence puts you as a practice at risk if a patient chooses not to follow the instructions. And I frequently found that. And one of the experts that I worked with at UCLA was very adamant that physicians cannot be traffic cops. You tell them what's expected, you anticipate that they will follow up, and if they don't, they need to be advised that there are adverse complications that can arise, including their termination from the practice, which should be a last result. Also, give them a list of community resources regarding transportation, prescription discounts, which, as Kathleen mentioned, also is a major problem for patients in not complying in prescription instructions. They don't take the medication because they can't afford it. And if there are discounts available and you can provide them with coupons so that they can get those, it works out much better. Also, as we saw since 2016, with the Cures Act of the 21st century, patients should be advised of the patient portal. Patients more increasingly are willing to cooperate if they know what it is they're being tasked to follow up on. And if they're told about the patient portal and they access that before each visit, then they know what's expected of them, and you do not spend a substantial and inordinate amount of time during the visit trying to review what the last visit entailed. Also, ask them to respond to reminder calls, and if you send written notifications reminding of important information such as appointments, referrals, make sure that they understand that. A lot of times practices don't have those types of follow-ups, and patients therefore, unfortunately, don't make notations and they don't follow up. And whatever the responses are that the patient makes should be recorded in the chart. I wasn't aware I had an appointment, you didn't tell me about it, and so forth. I personally had a recent experience where a practice told me that I wasn't following up, and I told them that I had been following up and that they didn't have any type of procedure in place for notifying me about important information. Document the understanding to the extent possible, including if you tell them the consequences related to continued noncompliance. Patients need to be advised that if they continue to be noncompliant, that will adversely impact the continuity of care, optimum treatment results, and it may also result, if there's continued noncompliance or non-adherence, to having them in a situation where they may be discharged from the practice. Non-compliant and non-adherent patients put you as a practitioner at risk for professional liability. And it's important that it's documented that they be told about those important considerations. Also, if it turns out that for whatever reason, either because they aren't following up with appointments, or if you have a telehealth visit and they don't participate, you should be prepared to send them a written letter. And through the doctor's company, we're able to assist you with those letters so that patients understand. Because one, it enhances the likelihood that they will continue with treatment options and programs, but also in the event of a problem, you're able to document at a subsequent time, both to health plans who require, if you're going to terminate a patient, that you properly documented the patient noncompliance or non-adherence, but also in the event of a litigation. And we see this periodically, not so much with professional liability cases, because that's second or third on the list. Patients tend to go online and make complaints on social media that a particular provider failed to provide them with adequate care or treatment. But it's also become very easy for individuals to go online and make complaints to the medical board. All they have to do is go to the medical board website. The first item that they can do is make a complaint. They touch that, and then there's an investigation. Of course, you will prevail in the vast majority of circumstances, particularly if your documentation is good, but it's better if patients don't take that step because they're advised early on that that's their obligation as a patient as part of the conditions of treatment. Then there's a concept called refusal of care. And in 1914 was the first case having to do with informed consent, a famous case out of New York that detailed what patients need to be advised. They need to be told as to what their condition is, what the options of treatment are, the risks and benefits associated with each, including the risk of noncompliance. In more recent years, we found that it should be documented because a lot of times patients, for cultural or language issues, don't follow the instructions. And therefore, you need to take the additional step of making sure the chart is properly documented. Documentation of a refusal should include the following notation: information that the patient was provided concerning his or her condition. This is the condition that we believe that you have. Here's what we recommend as your treatment plan, the course of referrals, medication, therapies, and so forth. And the reasons for treatment should be notated. A lot of times patients think that it's optional. Treatment recommendations are not optional. It's part of their obligations as a patient to follow those up. Also, refusal of care forms may be valuable. Many years ago, particularly in the emergency departments, we had an against medical advice document that patients were requested to sign when they were going to leave the emergency department. A lot of times patients would not sign that. Here's one that we recommend, and it appears on our website. And if you're given a copy of these various slides, we recommend that you use it. And it's important that the patient be asked to decline to sign the document. And if so, that a medical assistant or some other person in your office should be requested to say, patient was requested to sign this and refused to do so. Because if a patient is not going to follow instructions, my experience has been in doing this as of this past August for nearly 40 years, we find that patients are unwilling to sign that. They don't want to take responsibility, but it's important for you to make sure your documentation is complete and accurate. And if a patient declines to sign, that's fine, but there should be a notation by someone on your staff to indicate that. Because one of the things that I found over the years is that plaintiffs' attorneys make a concerted effort in meeting with patients to find out what transpired. Unfortunately, patients either don't remember or conveniently don't remember certain things that they were told. If the records are complete and accurate, a plaintiff's attorney, when reviewing a case in attempting to determine whether or not to accept the matter for litigation, will see that the patient was non-compliant, and they know that we win between 75 and 80% of all claims that are submitted for litigation. And if they don't have a very clear-cut opportunity, and I submitted an article for publication this morning in which I discussed this and will be published in about 2 weeks, if an attorney finds that a patient is non-compliant and the records don't substantiate their participation in their own care, the likelihood that the attorney will take the case is significantly reduced. Two things to that is if the records support what the practitioner did and that the damages are not significant. There is single-digit support for plaintiffs' attorneys in taking these cases. And of course, we want to make sure that patients are properly treated and get a continuity of care, and that if, because patient noncompliance or non-adherence, there is a bad or untoward result that occurs, patients should be responsible for that. And plaintiffs' attorneys are not willing to take on these cases and prosecute them in the event that it appears that a patient refused or neglected to do what they were told. And if possible,
could I ask you to, excuse me for interrupting, but I think something that is important is, could you comment about how also having a refusal to consent to treatment, medication, or testing, how that impacts if there's a medical board complaint and a grievance complaint, because that's, we're seeing that a lot. And how does that fare for for the physician if the medical record that they give as rebuttal documentation includes that the patient declined to sign and or they signed or they declined to sign. Is that helpful for the
Well, it certainly is, Kathleen, and thank you for bringing up that important point. I see a lot of requests for record productions that our members submit to TDC, and one of the things that we see are that the medical board more frequently than notices of intent to initiate a legal action complain to the medical board that they weren't properly advised. And if it turns out that the records are adequately documented, the medical board is entitled to obtain a copy of those records without a subpoena or patient authorization. And once they have had an opportunity to go through the records and they're able to determine that the patient was non-compliant and had been told of this, it's an expedited process. And usually the adversarial hearings that may take place in the event of a medical board complaint do not proceed, because it's clear that the practitioner did what was required by the community standard. Also, as we indicate in this slide, the last resort is patient dismissal. That's not in anybody's best interest to do that. And as Kathleen mentioned, frequently, particularly with managed care patients, the programs require that a patient have documented 3 instances where they were unwilling or unable to comply with instructions before there is a termination. And remember, and particularly since we're coming up to open enrollment, there can be a delay, and what we don't want is for a patient to have a dismissal or an interruption in care and an adverse result. As Kathleen indicated, that can result in a medical board complaint, but patients more and more, and we've seen this since the advent of COVID in March of 2020, patients are going online to make complaints, which can have an adverse effect on your brand. And because of HIPAA and the California Confidentiality of Medical Information Act, you're not authorized to respond to those in a way in which any protected health information is revealed. And the article that I submitted this morning makes very clear that you have limited options and can only indicate that you have an office policy in which you tell patients that they are responsible for bringing these to the attention of the practice, and that you will do your best efforts to work with patients to make sure that you resolve these in an amicable way. It is essential to document your recommendations, because plaintiffs' attorneys, medical boards, and others, including the Office for Civil Rights, once they get the medical records, if they see that what you did was reasonable and consistent with the community standard, that ends the investigation. And those can be very adverse to your brand and otherwise, including attracting new patients and making sure that you have support from the third-party payers, that your records demonstrate clearly that you did what was appropriate. Make sure that you address the patient's reasons for noncompliance. Patient may say, for example, I don't understand what I was told. It was done in a language that I don't understand. I was unable to attend the visit because of transportation issues. And as I mentioned a few minutes ago, it's important that you address those so that if a patient makes these allegations, you have already been proactive in establishing that you, as a practitioner of the community, have done what is expected of you. Also, if you terminate a patient, and we have a packet available on our website in dealing with discharging patients, what it is you should indicate. You should be explicit in the letter as to the reasons, and that may include that you advise them that it's imperative for a doctor-patient relationship to be useful, that there's proper communication, and that the patient has repeatedly, and I had one today in which there was very detailed information by an out-of-state psychiatrist in which we advised the patient the circumstances and the complications that developed as a result of the noncompliance, making it impossible for the practitioner to render standard of care treatment. Also, if there's specific dates that you can identify, and if you're a TDC member, we help you will be able to help you in drafting such correspondence, describing to the patients what they did, what they should have done, and the impact of their failure to comply or their non-adherence had on their ongoing care. And once you decide to send a letter of that magnitude, and it's very important, make sure it's either placed in the patient's chart, or if you have an electronic health record, to make sure it's properly scanned, so that at some later date, if a third-party payer, a medical board, the Office of Civil Rights, or even a plaintiff's attorney who's contemplating filing litigation will have that, so that they will know that you as a practitioner did what you should have done. And as Kathleen mentioned, many of your network provider contracts for payer provider agreements require, particularly with HMO patients, that you get prior approval from the payer. They require also that you demonstrate on one or more occasions in the record why you're dismissing a patient, because that can have adverse consequences for the third-party payer, and it can also have adverse consequences to a patient who has not been compliant, has not done what you've told them to do, and now you've made the determination. It may be necessary to tell them that you will only see them on emergency circumstances over the period of next 30 days. And as I've indicated, this documentation is available on our website, and we recommend that you contact your risk manager, whether for TDC or one of our fine competitors who have patient safety departments. They can assist you in preparing the proper documentation in this situation. If you have a question, have somebody in your office contact the HMO and make sure you get guidance from them as to how they interpret the payer-provider agreement. Patient does not or will not follow the treatment plans or the term of a patient pain management contract. Frequently, and particularly since the advent of COVID, patients are very willing to make a complaint to the medical board that you as a provider failed or refused to provide them with certain treatment. What they, of course, neglect to indicate is that it was contrary to what you had advised them was properly indicated. Also, they discontinue medication or therapy regimens prior to completion, which can adversely impact the continuity of care and optimum treatment results. Patient repeatedly cancels follow-up visits. That should be notated in the chart, and if possible, they should be advised in a follow-up letter that on this particular occasion, a follow-up visit had been scheduled. The patient had been advised of the visit 2 days in advance and failed to appear, and that adversely impacts their ability to maintain their proper treatment schedule. Make sure that you have some type of office policy about non-adherence, and if possible, post that online to indicate that you have this policy and that the patients the patient has refused to follow that. Because at some later date, if it becomes necessary to terminate the patient, you can indicate that you had that posted, the patient signed a physician provider agreement, and that one of the requirements was that the patient would follow instructions, including medication regimens, follow-up appointments, and referrals to experts, and that the patient refused to do that. Under process of law, both federal and state, due process requires that they be given adequate notice so that they can be told that they're required to do these things. And then once they've been given notice and they fail to do that, you become in a much stronger position in the event that termination becomes necessary for a variety of reasons, not the least of which is non-compliant patients tend to have less satisfactory results, and then they sue. Accepted dismissal criteria: verbal abuse or violence on the phone or in the office, absolutely unacceptable. And your physician provider agreement, as well as your conditions of treatment, should indicate that patients are expected to follow a certain level of decorum, both towards office staff and other individuals appropriately on the premises, including other patients. Some months ago, this past spring, I had a circumstance where, and it was outside of California, in a pediatric practice, a woman came in and was very rude to a small child and told the child that if the child didn't vacate the seat that he was in, and I'm still amazed by this, that she would undertake personal violence against the child and forcibly remove the child from the seat. The practice was excellent. They intervened. They advised the patient's mother that that was inappropriate. When the patient's mother persisted, they immediately contacted 911. 911 is very responsive, and I started my career as a deputy district attorney to complaints by medical offices that there is an issue. Make sure you contact them. It's not a violation of HIPAA. Indicate what the circumstance is, and a patrol officer will be dispatched to the premises immediately. It's not a violation of HIPAA because you as a practitioner are reporting an incident in which you as the practice are a victim of a crime and a crime is being committed on the premises. Do not allow individuals on the premises to sexually harass office personnel or other patients, visitors, or vendors. If you do allow that to happen, you may be subject to liability for failure to comply with state OSHA and employment laws relating to that. Also, do not permit anybody to make a threat of physical harm or to brandish a weapon such as a knife or a gun. Immediately advise law enforcement that that's happening. The record should be properly documented to make sure that this has been occurring, the patient has been advised, and law enforcement has been called. If they exhibit inappropriate sexual behavior, either to staff, to providers, or other people on the premises, they need to be immediately advised. Also, patients that participate in drug division, theft, or other criminal contact involving the practice, not only do they need to be advised immediately and prompt action taken, it needs to be reported in the chart. When I first started doing defense of professional liability and other healthcare issues, starting in the spring and summer of 1983, we were reluctant to put that in the chart. It's critical that it be documented in the chart because at a later date, if you just say patient was inappropriate, patient will respond equally in a vague manner and say, no, I was perfectly appropriate. If a patient makes threats or uses other terminology that is threatening, put that in the chart in quotation marks so that at a later date, if anybody were to review the chart, they know exactly what transpired. Also, non-payment of a bill is important. You as a practitioner have a reasonable expectation of being paid. A lot of times people will assume that you will not do anything about it. But if they owe a balance and then decline to work with you to make a payment plan, patients can be terminated. And of course, there are limitations on that. And I did an article this past spring having to do with termination of patients for non-payment. It's difficult to make a termination in the event that they're in an active phase of treatment. But if it's ongoing and it's routine care, patients need to be advised that they're required to make the payment and that failure to do so may result in one of two things. A, that they can be taken to small claims court, and that's appropriate, and it's not a violation of HIPAA because it's consistent with the HIPAA exception for treatment, payment, and operations. And two, it impairs your ability to treat them and makes it very difficult to maintain a doctor-patient relationship if they're unwilling to follow their obligations. Kathleen, if I could turn this back to you to address exceptions and special circumstances related to dismissal, please.
Thank you, Rich. That was a great overview. And if you have any questions, you can put them in the chat too. And Jen will let us know. We're coming up on the end, but I do want to just comment a little bit on a couple of exceptions and circumstances that are special. And if a patient is in an acute phase of treatment, then you have to wait until that acute phase of treatment ends. This would be like someone who is post-procedure, post-operative, if they have not completed their diagnostic workup. If you are not feeling that you are the provider that doesn't feel comfortable to continue to see this patient for any number of reasons, you can say you can come back to the office, but I'm not going to be seeing you, or you have your office manager say, Dr. Cahill is not going to see you. We have 2 other physicians, or we have a PA and NP that will see you on the next visit so we can finish the testing. And if a patient says, for instance, well, if I'm not going to come back here at all, you want to be sure that you document that. And as Rich said, you want to use the patient's words. So patient advised Dr. Cahill will not be available, offered alternative provider in the practice. Patient responded in quotation marks, I'm not coming back here at all, because that is the patient dismissing you. And in our dismissal packet of letters and sample template letters we have, there is one exactly for that, where the patient discharges you. That's different. But we still have to be mindful, and that's why it's always a conversation. And we like for TDC, if with TDC, call your risk manager, and we can help, give you some guidance. If you are the sole source or the only person that can provide certain care or treatment within a reasonable driving distance, then you have to be concerned about dismissal. But you're in a pretty urban, suburban area, San Diego. There are some outlying areas, and you get down into Imperial Valley in that area, people might come a long ways, but there's not so much to be. It's not considered a critical access area at this time, really. And also, pregnant patients represent special circumstances. And the easiest way to say it is, if you're dealing with a pregnant patient in your OBGYN, don't try to dismiss them after the 20th week, because that's really the cutoff line. So you have to be sensitive to that and get them dismissed before they hit the 20-week mark, because it's very difficult to dismiss them, and other physicians don't want to take them on after 20 weeks either. And so during the first trimester is the time to end the relationship for an uncomplicated pregnancy, and the patient has time to find another practitioner. During the second trimester, ending a relationship only for uncomplicated pregnancies if the patient transfers to another practitioner prior to the cessation of your services. So they're saying, I'm not going to continue to see you. You need a new physician. Check with your health plan network, whether they are Medi-Cal or with a health plan or Covered California. And that then will come back to, they'll say, well, what are you dismissing them? What's the grounds for dismissal? Show me your 3 documentations. You can't just let people go, send people out. And so we have to have an appointment with somebody before that person can go. And sometimes patients try to game this, and so they intentionally don't make an appointment. And of course, there's letters that are sent, and all this is documented. During the third trimester, really, you really can't end it unless there's extreme circumstances. The illness of a provider, maybe in a solo practice, a physician passes away, and is there someone else in the practice that can take over for that patient? When is patient dismissal prohibited? I'm not going to go through the detail on this slide because we're coming up on the hour and I want to get to the questions. You want to be mindful of no discrimination. So nothing that violates the Americans with Disability Act. We can't dismiss them because they're hearing impaired, because they're in a wheelchair. Civil Rights Act, the Affordable Care Act. And, the Department of Health and Human Services outlines all requirements for non-discrimination policies and notices. My last slide is one of my favorite of the night, Dalai Lama, who said, do not let the behavior of others destroy your inner peace, because these patients do destroy your inner peace. You get frustrated, your staff gets frustrated. It's difficult and challenging to work with them. You don't get the results you want. They complain, they will make negative reviews, they make grievance reports, they do report to the medical board, and it's very frustrating for you. So think about this. You have to really, compartmentalize when things happen. One of the things your risk manager does is take your call and let you walk through it and talk about some ways and strategies to deal with it. I want to remind you that you can get CME credit. If you have a smartphone and open it to your camera, you can scan the image in the center. That's called a QR square. You can also type doctors.cnf.io, which is right here highlighted in yellow, in the URL, which is at the top. It's not on this slide, but at the top of your screen. And that will take you right to our website. And the evaluation is up. It's very important after you sign in and do the evaluation. You have to sign in, check in, hit check in, and then go back and it'll say complete the evaluation, but you must scroll to the bottom of the evaluation after you complete it and hit submit. If you don't hit submit, it will not submit it. If you have any problems or concerns, you can, there's a contact person here, Tina Wheeler, in our department. So Jen, can we turn to these questions? But first I want to apologize for the technical issues tonight. We've never encountered that before, so we don't know what it's about. Well, we will try to troubleshoot it. So we apologize. And I do just want to make a commercial message, because our last program of the year for the San Diego Medical Society is going to be on November 8th. And that is November 8th, strategies to enhance the patient experience and decrease your risk. Because the other thing that's beating you up is the patient experience scores on Press Ganey and customer feedback and customer satisfaction. So we're going to give you some great strategies that you can employ. Jen, I'm going to turn it over to you for the questions.
Thank you, Kathleen. So one of the questions that did come in was one of our attendees is asking for the publications, a link to the publications that Rich had referred to. Rich or Kathleen, if you can email that over to me, I will make sure to get that sent out to everybody that was on the presentation this evening.
I will do that. I will send it to you, and I apologize because I requested that slide be added, and apparently it wasn't. So I will send it to you, Jen, and you can send it out.
I will send that out along with a copy of the slides and a reminder of how to claim the CME credit to everybody. Just two quick questions before we break for the evening. Rich, do you have any suggestions for handling the refusal of care forms in the era of telehealth? Maybe not having reliable internet or computer access when the patients are not physically present in the office.
Well, it becomes problematic because refusal of consent or refusal of care is important to demonstrate because it's patient non-compliance. And if you have a patient who is being treated versus telehealth and they're not physically present, you'll have to do that in the next best way, and that is to advise the patient that if they don't cooperate, a notation will be made in the chart. And then that should be done either by the provider or by a medical assistant, that the patient was advised, acknowledged that that was the recommendation, and made a conscious decision not to follow up as instructed. Plaintiffs' attorneys, medical boards, and Office of Civil Rights are less inclined to undertake any type of punitive action if it's clear that the patient was advised but made the voluntary decision not to cooperate.
One of the things that I've heard back from physicians with this question, because it's a frequent question, is to say to the patient, they say, I'm not in the office. I say, I want you to sign something, but you're not in the office, so I'm going to mail it to you with a self-addressed stamped envelope. And patients will say, well, fine, but I'm not going to send it back. Okay, well, then I'll note that in the record. And you put that in the record in quotation marks. I'm not going to sign it and send it back. And then you can write decline to sign. The physician can still write decline to sign and make the notation. So you can also do that.
Kathleen, one other question. What would you suggest for patient dismissal if a patient has a gender requirement in a group practice? Example, they only want a male versus a female doctor and is refusing care otherwise.
Well, this is coming up more and more, and there's a two-part answer. First, I want to talk about the patient who comes and there's a concern, and the physician shouldn't be, and I'm talking right now about like gender transformation patients, because I'm getting a lot of calls about that, is that the physician has to have training experience and, actual training and experience to take care of these patients. And I'm in Orange County, and here the physicians in Orange County, they know who the sites are. They refer to UCI, which has a very robust department to deal with all gender issues. And they also refer to Children's Hospital of Orange County, because they likewise for minors have it very. So they say, I would like to care for you, but I want you to get the very best care. And so I would like you to go where the best care is, where every day they're taking care of patients that face the challenges you have. and you do it very gracefully. Then you have the situation where the patient says, I only want a male, or I only want a female, whether what their gender is immaterial. You have what you have. So you say, I'm sorry, you want a female and we only have male. That probably we're not going to be a very good choice, because we don't have any other option. You might want to check your health plan network and see if you can find what you're looking for, a male. It was interesting that I was just doing some research and looking in some sites that some practices are now allowing you to schedule online. And one of the questions is, it's like, when do you want to visit, the time of the day, is what gender do you want of your provider? Male, female, or, no preference. That's new. I hadn't seen that before, and I've seen that on a lot now. So the patient has the right to have what they want. If they show up, and I had that last week, where a patient showed up for a GYN exam, and it was a male patient, and she was irate because she said, I don't want a male, and they didn't have a female available for what she needed. And she was upset and made a big scene in the office. And she said when she made the appointment that she said, I only want a female. Now, nobody could remember when she called, because she called and they use a call center. So nobody knows what they said. So you can't do anything about that, right? So they apologized. They called me and said, what? The doctor called me. He stepped out of the office. He said, what should I do? I said, apologize. Say, I'm very sorry. We do have a nurse practitioner available. She'll be happy to see you. Patient didn't want any part of that. Patient stormed out, and I helped him in drafting a very kind, gracious letter, because, two wrongs don't make a right. The practice wasn't wrong, and the patient doesn't think she was wrong. So we have to try to make the best of the situation. But when people make an appointment for the first time, they usually will say, I don't want a male, or I don't want a female. That should be put into their chart. So that notation should be made. But if they don't want to see you, then they have to leave, and you give them back their copay and they leave. And I think a letter sent, it's not that it's an apology letter, other than we're sorry you weren't pleased with your visit in our office. It had not been communicated that you specifically requested a certain physician or a certain gender. So those are kind of one-off things, but I'm getting a lot of calls about the other one, about gender transformation, especially from plastic surgeons and dermatologists.
Thank you, Kathleen. One other question. Kathleen, can you discuss very briefly how to manage a patient that doesn't follow up due to either memory or dementia issues? What should the office do about that? Does it make it more difficult for the provider regarding litigation?
Well, one thing that needs to be really important to hear is, if you have a patient who has some cognitive deficit, or you're noticing it, the first thing is a referral to a neurologist to get it evaluated. And when patients, the competency evaluation for competency that the courts require is evaluation assessment by either a neurologist or a psychiatrist. So I get a lot of calls about people who say, my mother she doesn't know what she's doing, and I need to make all her decisions, and they don't have an advance directive. And an advance directive is when the patient can't make decisions, but the doctor will say to me, this patient, the daughter called and said all this to my staff, but I have no problem communicating with the patient. She's very lucid, oriented to person, place, and time. And I think the daughter's coming out of left field. What should I do? I said, well, first of all, the patient, we looked, the patient hadn't signed a HIPAA authorization. So there's no authorization to talk to the daughter, because that's a HIPAA violation. The patient must give a consent in writing, verbal consent. There's no such thing as verbal HIPAA consent. The only way that works is if the daughter came to the visit with her, and it's implied consent because she's with her in the visit. And then the daughter leaves and calls and has a question. I'm sorry, we follow all federal and state privacy laws, and your mother has not signed a HIPAA authorization, so we can't speak with you. You might want to talk to your mother and see if she wants to sign an authorization. So it's really important that the patient get assessed. But I find the most frequent call I get is a family member is upset that the patient has a deficit and the doctor doesn't see it much or at all in the visit. And the other thing is to say, why don't you invite your daughter to come with your next visit? And when daughters call and make complaints, then I think it's also as a courtesy. If my daughter called my doctor and said something about me and you said, well, we can't talk to you because Kathleen didn't sign a release, I would expect my doctor's office to practice to call me and say, I want to let you know your daughter called and was really upset and said she feels like you have, some cognitive deficit, and that we need to give her the responsibility, your daughter, of making your choices and your consents, and you're having a surgery coming up and the daughter wants to be the consenting party. It's just like if you get an attorney request for patient records, a subpoena, or just from an attorney, the right thing to do is to have your office staff call that patient and say, we received a release and an authorization today from Attorney Joe Blow asking for your records, and it's a signed authorization, but I just wanted to confirm with you that you want these records released. Do you know how many times people say, I didn't sign anything, I don't want those records released? People are in estate fights, they're in divorce fights, and they're trying to get doctors' records. So you really need to understand the patient has the right to know, even if you get a signed release, it's a phone call and document patient called, patient says, please request records. Same thing with a subpoena. We got a subpoena and those come to us to Rich reviews all of our subpoenas. But I said, did you call the patient first? Because I said, I want to know before I go to give it to our attorney, I want to be able to say the patient is aware and wants it released, or at least by the time he gets it, I'll know. So it's a phone call, and that phone call should be documented in the patient's record.
Thank you, Kathleen. No, I think that'll do it. We want to thank everyone for taking time out tonight to join us for another terrific presentation. We really appreciate everybody putting up with our slight technical issues and hanging until the very end. We had a lot of people that stayed on till the very end. I will send the link to the information that Rich discussed, the presentations, and I will also send copies of the slides to all of our attendees tomorrow. Kathleen already stole my thunder when she mentioned that we do have our next program in November. I believe it's November 8th. So please be on the lookout for our emails that come out where you can register to attend that program as well. Lastly, if you are a physician, not yet a member of the Medical Society, we would encourage you to visit our website where you can find out more information about benefits of joining, and you can join online in less than 5 minutes. Thank you. Have a great night, everybody. Bye-bye.